Hello, I am Rosalino Vázquez López, a research at the Universidad Anáhuac, Mexico. My team and I appreciate the invitation in this second edition of COVID-19 International Congress. One of my line of research that I have developed with my friend, Dr. Rodrigo Martinez, is the study of comorbidity factors associated with the SARS-CoV-2 infection. And this is a pleasure for us today to present the investigation entitled A Study of Blood Groups in the Mexican Population and its correlation with presentation of COVID-19. Thank you.
Thank you, Doctor. As you can see here in the diagram on the left, SARS-CoV-2 uses its spike proteins which have the receptor binding domain, which bind to the host cell through the angiotensin-converting enzyme 2, facilitating its entry to the cell. ACE2 is known to be expressed throughout the body. As you can see here, in this diagram on the right, it's expressed in the brain, the lungs, the heart, the kidney, the vasculature, pretty much every organ, and this is due to its highly crucial role in blood pressure modulation through the renin-angiotensin-aldosterone system. Not only does the binding of the enzyme with the virus allow its entry, but it also affects directly ACE2. It actually downregulates the enzyme itself, affecting this system, which we will further explain in more detail. Talking about the physiopathology of SARS-CoV-2, the virus entry elicits predominantly a Th2 response. However, there is also a Th1 response, as seen with the release of various pro-inflammatory cytokines, such as interleukin-6. It has been suggested that the virus also activates the cGAS, STING, and p38 MAP kinase signaling pathways, resulting in a drop in TCD4 and TCD8 cell counts, as well as an increase in interleukin-6 levels. The ACT-mTOR signaling pathway is stimulated, while CDK1 is inhibited, resulting in cellular arrest in S and G2 phases, allowing the virus to keep producing proteins without running the risk of termination due to the overruling of apoptotic mechanisms in the cell. However, due to the virus's high energetic quota, the infected cell's mitochondria won't be able to keep up, and they will start malfunctioning, resulting in the release of DAMPs, stimulating the HIF-alpha sirtuin pathway, resulting in sepsis, hypoxia, and a hyperinflammatory state. Talking more about the immunology of COVID-19, the infection can be roughly differentiated into mild COVID-19 infection and severe COVID-19 infection. The mild COVID-19 infection is more or less what I just explained in the last slide, but to summarize it, the cGAS STING pathway is activated, resulting in the release of inflammatory cytokines, predominantly interleukin-6, as well as a drop in TCD4 and TCD8 cell counts. However, the severe infection is a little bit more elaborate. Just like the mild infection, the cGAS STING pathway is activated. However, T cells are also activated, resulting in the release of interferon gamma, which with the addition of interleukin-6 can result in the development of cytokine release syndrome, which can evolve quickly into cytokine storm, characterized by the release of pro-inflammatory cytokines such as interleukin-1, interleukin-6, and interleukin-10, which have been associated to inflammation, fever, and malaise, interleukin-13 and interleukin-14, which have been associated to pulmonary damage, tumor necrotizing factor alpha, which increases the vascular permeability and has been associated to ARDS, and finally, Phycolin-3 deposits in the pulmonary microvasculature have been associated to the development of thrombosis in COVID-19 patients, as well as the activation of the coagulation cascade due to high levels of inflammation. Additionally, the complement system is also activated, resulting in more tissue damage, specifically the lungs.
Now, talking about ABO and Rh blood groups as comorbidities in COVID-19, it is well known that blood groups have been classified subject to the antigens they express. Blood types A and B's antigens differ by an N-acetylgalactosamine, whereas O types there is an H antigen and a galactose present. That is the reason for which the immune system activates after the transition with an incompatible blood type, thus leading to hemolysis and a potential risk of death. Blood types O and Rh negative are referred to as the least susceptible to develop COVID-19 infection, while A, B, and AB types are associated with a greater risk of COVID-19 infection, along with Rh positive. In as much as these last blood groups are concerned, this is due to the fact that they facilitate the viral molecular contact. And it has also been suggested that lower levels of ABO antibodies are related to a higher risk of infection. Therefore, the high ABO antibodies levels present in all groups with anti-A and anti-B antibodies, as well as Rh negative, are considered protective factors within the general population. As mentioned before, presumably, by reducing ACE2's presence, SARS-CoV-2 has fewer molecules to adhere to in the host cell. O and B blood types, by sharing the anti-A antibody, result in an inhibition of ACE2's expression, consequently reducing the likeliness of infection. Blood type O is also the least susceptible to develop thrombosis, vascular and respiratory dysfunction compared with other groups. Nonetheless, when faced with an infection, there is evidence that suggests that they require more oxygen therapy and take a longer time to recover. Unlike other groups, blood type A increases the probability of developing the disease, more likely in a female type A patient, leading to complication, mechanical ventilation necessity present in type AB as well, severity significantly higher with an antecedent of cardiovascular disease, and mortality. Regarding B and AB types, they are more likely to be intubated, to have a greater death risk, especially high in AB type compared with A or B. B type is particularly susceptible to develop thrombosis following the disease. However, some authors have mentioned that the relation between type A and the disease severity is still inconsistent.
As we explained, the virus enters the cell through the ACE2 receptors, which are part of the renin-angiotensin-aldosterone system. This is a peptidergic system that acts in the homeostatic regulation of the renal and cardiovascular systems, regulating the extracellular fluid volume. We know that an increase in ACE2 activity leads to a downregulation of ACE2 receptors, resulting in a local accumulation of angiotensin II, and this can shift the balance of the pathway, resulting in low levels of angiotensin 1 through 7 and high levels of angiotensin II. This directly leads to disease and inflammatory protection, and this could explain the origin of the comorbidities in COVID-19. I'm going to talk right now about hypertension as a comorbidity, and we know that ACE2 is a modulator of the RAS, which is a critical neurohormonal pathway that regulates blood pressure and fluid balance. The end product of the RAS is angiotensin II, a vasoactive hormone that binds to angiotensin II receptor type 1, located in the heart, lungs, blood vessels, kidneys, and adrenal glands. And this plays a central role in myocardial hypertrophy and fibrosis, inflammation, and vascular remodeling. And we know that RAS inhibitors are a common treatment among hypertensive patients. All of the current knowledge right now is based on observational studies that can demonstrate an association but do not establish a causation. Therefore, the American College of Cardiology, the American Heart Association, and Heart Failure Society of America advise not to discontinue RAS treatment on hypertensive patients, and this position is also supported by major international scientific societies. Obesity is another important comorbidity because an excessive or an abnormal fat tissue accumulation can alter the innate and adaptive immune responses, leading to patients more prone to infection and less responsive to vaccinations, antivirals, antimicrobial drugs because of this immune system dysfunction. During obesity, the systemic inflammatory status is influenced by an intense pro-inflammatory cytokine secretion, increasing the chance of a cytokine storm. Therefore, individuals with obesity tend to be more susceptible to COVID-19 infection and progression. These patients show abnormal RAS activation, high ACE2 levels, low angiotensin 1 through 7 amounts, decreased antiviral immunity, and the presence of lipid deposits in large airways, which potentially act as a viral reservoir in the heart and lungs. It acts as a reservoir because ACE2 is highly expressed in adipose tissue. And diabetes is another important comorbidity because the individual degree of hyperglycemia seems to be independently associated with COVID-19 severity and increased mortality. Studies have shown that in human monocytes, elevated glucose levels directly increase COVID-19 replication, and glycolysis sustains COVID-19 replication via the production of mitochondrial reactive oxygen species and activation of hypoxia-inducible factor 1 alpha. However, we know that acute respiratory virus infection increases gamma interferon production and it causes muscle insulin resistance in humans, which drives to a compensatory hyperinsulinemia to maintain euglycemia and to boost antiviral CD8 T cells responses. It also activates natural killer cells as a defensive mechanism. So an increase in both gamma interferon and activated natural killer cells exacerbates systemic inflammation in muscle and adipose tissues. Overall, establishing a detrimental effect on glucose uptake, the natural killer cell activity could explain why patients with diabetes are more susceptible to COVID-19.
Important factor is a different impact that has been caused by the virus SARS-CoV-2 depending on the gender, since it has not been the same in women and men. This is explained by the various factors that the evolution of the sickness depends and are involved on. For example, sexual hormones. It has been observed that COVID-19 affects twice as many men as women, exhibiting an increase in severity and mortality of the sickness. On top of that, we point out their close relationship between low levels of serum testosterone and inflammatory cytokines, aging, lifestyle, and evolution of the sickness. All of this being positive factors to contract the disease, proving that all the factors above mentioned contribute to the creation of an ensemble that provides the perfect environment for the virus, allowing SARS-CoV-2 to produce a lethal effect in our organism. As mentioned before, SARS-CoV-2 uses the angiotensin converting enzyme 2, ACE2, to enter the cell. This enzyme is expressed in high quantities in different organs, such as the heart, testicles, and kidney. It is also of our concern to point out that testosterone induces a prompted and positive response towards the virus, which leads us to consider that testicles, primarily the leading cells, a so-called Diana organ for COVID-19. In men, testosterone decreases by 2% per year since they turn 30 years old, and this drop goes on for the rest of their lives. Meanwhile, women, testosterone serum decreases earlier in life, between the ages of 20 and 40, and stops then when they develop menopause. Usually, testosterone levels increases during the ages of 60 and 80 years. Men who have low testosterone levels are considered to have important health defects, such as endothelial dysfunction, thrombosis, defective immune response, or systemic inflammation generated by serious lung problems that need advanced attention. Testosterone is not only factor or reason that explains why men are dying more than women when they contract COVID-19. For the genes encoded on the X chromosome play a positive role in the development of the immune system response. In such scenario, men who are provided with only one X chromosome become more susceptible to contracting COVID-19 and have a less favorable evolution of the disease than women do. As we can see in the graphs, in the Mexican population, more cases of infected men between 30 and 34 years of age than women were reported. And in the same way, the number of deaths in men significantly exceeds that of women.
I'm Professor Rodrigo Martinez Espinosa. Our group recently carried out a pilot study that evaluates some of the characteristics of the Mexican population of 120 young adults and the risk of having COVID-19. In the population studied, 41% were men and 78% women, with an average age of 21 years. It is very interesting to know that in this open and totally random sample, 50% of the people present at least one comorbidity related to poor prognosis against COVID-19. A data of interest was the distribution of blood groups, the most prevalent being group O positive, with 60% of the participants, followed by A positive with 22%. Interestingly, there was only one individual with severe COVID-19 that was hospitalized and who had AB positive blood type. When evaluated how many people had two or more relatives with COVID-19, 13 people answered affirmatively. Of these 13 people, 23% were AB positive, and another 23% were A positive. In the case of AB positive, only 3 persons were detected in the entire population studied. All 3 reported having 2 or more relatives with COVID-19. Although preliminary and small in number, the first data from our study shows that there could be, as some researchers have already reported, a different predisposition to COVID-19 given by blood type groups. In conclusion, blood groups seem to have a role in the development of COVID-19. However, more information and studies are needed to know the relevance of the blood type in the development of this disease.